Hello and welcome to CQC Connect. My name's Bernadette Hannay and I'm Head of Hospital Inspection here at the Care Quality Commission. It goes without saying that the coronavirus has had a huge impact on the whole of health and social care. Here at CQC, over the last few months, we've been engaging regularly with a group of senior clinical emergency department staff from hospitals across the country to understand the pressures they faced. And we formed a forum called the National Emergency Medicine Special Advisors Forum. We've heard from these clinicians about the steps being taken to manage infection risk, adapt to social distancing rules, and ensure the best possible care for patients. We'll talk about what the challenges have been, share learning and innovation, and hear from the clinicians who have been on the front line. Today, we're going to be talking about reduced demand and improved capacity. And I'm joined by two of the members of the National Emergency Medicine Special Advisors Forum. Can I ask you to introduce yourselves, please? Let's start with Baz.
Thank you. So my name's Baz Sen, and I'm Emergency Medicine Consultant and Associate Medical Director at the Royal Victorian Infirmary, Newcastle upon Tyne. I'm also the EM Regional Clinical Advisor for North East, North Cumbria and Yorkshire. Thanks.
Thank you, Baz. And Baz?
My name is Vaz Ahmed. I'm an emergency medicine consultant at Addenbrooke's Hospital at Cambridge. I'm also the STP lead for urgent emergency care for Peterborough and Cambridge.
Thank you very much, Vaz. So to start us off, could you tell us briefly about the impact that coronavirus has had on your area of work and what the biggest challenges or concerns are as we head into winter? Baz, would you like to go first, please?
Thanks, Bernadette. So I think coronavirus has had a huge impact on our area of work. In a very short time, we had to learn how to deal with a new virus, in which cases we had to isolate patients and avoid the spread of infection to new areas. Now, the reason we found this difficult, it's not that emergency medicine has not dealt with exotic viruses before that need to be isolated. It was the sheer volume of the number of patients that attended with this virus. So for those of you, most of you will know, but for those of you who don't, coronavirus in its early stages presents as a common cold with fever. And by and large, these patients are very common when they present to the emergency department. So the challenges we faced were, firstly, to isolate them as they walked in. Secondly, to stop the spread of isolation, to stop the spread of infection. And finally, there were procedures we would have to do to make these patients better, which actually resulted in a huge risk to staff and patients. And they had to be done in contained areas. So there was a lot of adaptation that had to be done.
Thank you, Baz. That's really helpful. And Baz, I just wondered, thinking of what Baz has just said, as we approach into winter, what are the challenges going forward now?
I think one of the things which coronavirus and the pandemic itself brought along was the challenges on its staff, basically. I think going into winter, there are two things which is my concern. One of them is the capacity to manage the patients coming through our emergency department. And the second bit is the resilience and the well-being of the staff who are dealing with it. Because as Baz just mentioned earlier, we had to adapt to a constant change, which in itself was quite challenging for our staff. The isolation and the segregation has brought itself new challenges, which brings in itself the difficulty of how staff deal with this group of patients. Lastly, I think it also brings that the crowding within the emergency department has magnified itself because we've had social distancing, so we can have less number of people in the emergency department, so we can't deal with the same number of patients who used to present before COVID started. So I think those are the couple of challenges, one for patients, two for the staff.
Thank you, Vaz. I think just on that, we know that emergency departments need to be able to focus on the critically unwell or injured patients who need rapid assessment and intervention. And to do this, they need to maintain a manageable number of attendances. And as you've just said, you need to have less people in the department in the current environment to maintain social distancing and other infection and prevention control measures. I wondered if you could talk us through some of the things that you think are key to maintaining that manageable number of attendances in the emergency department. And Vaz, would you like to start us off on that?
Yes, thank you. First of all, I think we have to make sure that the patients who are within our emergency department who needs admission to the wards are moved out of the department as quickly as possible. That is our biggest impact at the present time for crowding within an emergency department. The second aspect, which actually has got marginal gains, is the patients who are walking into our emergency departments and what we do with those group of patients. So one of the things for example, where we have started in Cambridge is that we would patients who haven't been seen by their GP or they haven't been sent by NHS 111 or any other healthcare provider, if they don't need to be in the emergency department, they are redirected back to within the community if they're safe to do so. The second aspect we have put in place is streaming all the patients who don't need to be seen in the emergency department. For example, if someone has had a surgery and they have come with a complication to the emergency department, they are then streamed to the appropriate places within the hospital. So I think the crowding becomes to reduce crowding, we have to tackle the problem from different angles. One is the exit block. The exit out of the emergency department needs to be seamless. The second bit is we need to reduce the number of patients walking into our emergency department as well. So if you don't do both of them, your emergency department will be crowded, and the gains you get from when you combine both of them is quite massive.
Thank you, Vaz. Vaz, do you have any specific examples of how you've managed to reduce the number of attendances that you'd like to share?
So I think I would agree with what Vaz has just mentioned. And have we done anything specific in Newcastle to reduce the demand? We absolutely have. And the thing that I would recommend is something similar to what Vaz has said. We stream right from the start. So when a patient comes in, the patient actually reports to a band 6 or a band 7 navigator. The navigator streams the patient appropriately to say either minor injuries unit or primary care service, same day emergency care, specialist clinic. And by doing that, we have managed to reduce the number that goes into our majors department. I do have a vision, and my vision is this, that majors emergency departments only sees blue light emergencies. By that I mean ambulances that bring in ill patients via the 999 route. We think A&E majors should only be dedicated to 999 emergencies, and that will reduce our workload so we can manage these patients appropriately. Thanks.
Thank you, Baz, and that takes me nicely onto the next question, which you may wish to continue on, and that is about what do you think the barriers are that stop emergency departments being able to focus on the patients that need the most attention, so those sickest patients that you have in the department?
So that's exactly right. So I think that's an easy question, and the answer is the demand. And the reason EDs have faced this tsunami of demand is because they're a well-known brand. They're open 24/7. And if there's any doubt in the patient's mind where to go, they end up in the emergency department. We have long experienced this, and I suspect it won't end anytime soon. But given some of the measures that Vaz mentioned before, maybe we can make it more manageable.
Thank you, Vaz. Vaz, is there anything that you want to add to the barriers that stop you being able to focus on the patients most at need?
So I think one of the things I would like to highlight is that different systems have different strengths. And some places, for example, urban areas and so on, you may have a lot of patients who are coming in who haven't seen a healthcare professional, versus another area where patients have seen their GPs or healthcare professionals and they turn up in the front door of the emergency department. I think the solution for those two places are completely different. And sometimes you may have to focus on one issue before the other. So, for example, if you in Cambridge, we have our GPs are very good in the sense that a lot of our patients present to the emergency department after seeing a clinician or a healthcare professional. But there is still a small group of patients. So what we have done is we have started direct booking in, not to the emergency department, but to our urgent treatment center to manage that small group of patients who could be seen there rather than be seen in the emergency department. This basically shifts the patients from the main area to the co-located urgent treatment center. And that goes back to what Baz has said, and I have the same vision as what Baz has got, in the sense that our major area should only see non-walking patients and who are emergency medicine patients and who need the care for, who needs the doctors to care for them, and they should be free from other patients who can be seen from in other places.
Thank you for that. That's helpful. And I think it's interesting. We started by talking about, Baz was talking about, this is a new virus. We need to isolate patients, prevent the spread. And in talking about some of those challenges of coronavirus and indeed the winter pressures that have been faced over the years, you've also talked about some of the examples of good and innovative practice that you've done in response to those. But I just wondered if there were any other examples of good practice that have been introduced during the peak of the pandemic that have been adopted that we haven't given you a chance to talk about so far. Vaz, would you like to go first?
Yes, of course. I think one of the things we did very early is that we moved our minor injuries to co-locate with the urgent treatment center, which is just around 50 yards next to the emergency department. And this initially we did this because we needed to create space and help with the segregation and reduce the crowding. But what we have noticed and what we have learned is that the working between the emergency nurse practitioners and the GPs have helped us to run this area in a very effective way. And that means we are seeing around 110 to 120 patients out of 300 in that area in a very efficient manner and very quick manner. And the second example I'd like to give is streaming patients to red and green pathways 24/7 through the whole hospital, which then tends to take the pressure off from the emergency department. And as we explained about how the doctors and the nurses in the emergency department can manage the emergency medicine patients. So I think those two examples of having 24/7 pathways for streaming into the rest of the hospital, and probably in our example of co-locating the minor injuries with the UTC, has really, really helped us.
That geography of the department and its associated areas and being able to see the right patients in the right time is the nub of the first part of what you said, I believe, Baz. Baz, have you got any other examples of good practice that you'd like to tell us about?
Thank you, Bernadette. So what I was going to mention is that we learned from Italy and from London in Newcastle. What we learned was that if we could spare ICU capacity, then our hospitals had a much better chance of dealing with this enormous number of people presenting who were quite ill, really. And the lesson we learned was that these patients needed oxygen, but they also needed the oxygen delivered through a pressure mechanism. Initially, Italy thought that the only way to deliver this would be to intubate them. But in Newcastle, one of our respiratory physicians felt that we could deliver oxygen equally well by a process known as non-invasive ventilation. Now, the thing with non-invasive ventilation is that the patient stays awake, the patient is sitting up, and when the patient comes off the non-invasive ventilation, he is not as ill and doesn't need a long recovery period. So we actually cohorted these patients into a semi-intensive care area, but they recovered more quickly, and therefore we did not use as many intensive care beds as we needed to. And this really led to an increased capacity in the whole of the hospital, leading us to a better flow in the emergency department. The other thing our ITU team did is they understood that to intubate patients within the emergency department was a high-risk procedure. So as soon as they identified the patients who were ill, along with the emergency medicine team, the patient was removed to the intensive care area and intubated up there. This left the emergency medicine department free to deal with the new patients that came in. I was so impressed by the way they worked, and I was also impressed by the way the specialists worked. The consultants of the specialties, like general surgery and orthopedics, came down and saw the patients themselves, and that really helped us. Now, unfortunately, some of that practice has tailed off, but as you know, we are kind of into the second peak, and I'm hoping that we can reinstitute some of the practices we saw last time.
Thank you very much. That's really interesting, because I think there's a principle to what you've both said about making sure that patients are treated in the right place at the right time by the right people with the right expertise. And I think the ITU and the links with that also demonstrate that any issues in an ED department have to be owned by the whole hospital has to come together to address those, and indeed the system beyond that. So that's really helpful.
Thank you.
So finally, my last question is if for each of you, one thing that everyone could do to help with demand and capacity, if there was one thing, what would that be? Vaz, would you like to go first?
Yeah, thank you. For me, the one thing would be that the whole of the emergency pathway is bought in, or the board buys into the whole of the emergency pathway. It is about getting everyone on the same page and making sure what Baz explained just a bit earlier. During the coronavirus peak of its pandemic, we saw an amazing amount of teamwork, which we did not see pre-COVID. And I would think that that's because everyone felt they're in it together. And I just think that going forward, we probably need to harness that in every trust within the country. And that would make a massive difference to the flow, especially with the capacity and the demand for emergency patients.
Thank you, Vaz. And Baz, your one thing?
So my one thing is streaming. And if I had to say two things, it would be streaming and streaming. And if I had three, it would be streaming, streaming, and streaming. I just can't emphasize how important streaming patients at the front end of ED is.
Thank you so much for joining me today. It's been so interesting to hear your reflections, and I'm really very grateful for you taking the time out from your busy jobs to come and speak to us. And also thank you to those listening as well. And there'll be more podcasts, so keep an eye out for those over the coming weeks.